Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Insulet. It is the policy of Medscape Education to avoid the mention of brand names or specific manufacturers in accredited educational activities. However, trade and manufacturer names in this activity are provided in an effort to provide clarity. The use of brand or manufacturer names should not be viewed as an endorsement by Medscape of any specific product or manufacturer.
Hello, everybody, and welcome to Ask the Experts. Today, we're going to be talking about how to reduce burden and simplify life with AID. I'm Dr. Kristen Castorino, and I am at Sansom Diabetes Research Institute in Santa Barbara, California. And I am delighted to be here today with Dr. Pablo Mora, who is in Texas. And I'm really excited to talk to Dr. Mora, particularly about his experience, not only in the trials for AID and type 2 diabetes, but also his real world clinical experience. So let's dive right in. So, as you are well aware and have been in the weeds of it, quality of life is a key component of type 2 diabetes. The way people feel and how successful they feel they're doing is will really make or break our therapeutic choices. And progression to needing multiple daily injections, particularly mealtime insulin, is really associated with treatment burden and stress. Patients really have a difficult time doing it, and providers have a difficult time finding a way to help their patients bridge that expanded need for insulin. And what we also know is that this is a vicious cycle. When a person needs more insulin or needs insulin at certain times, like mealtime or multiple times throughout the day, that can cause distress, which then can lead to worsening self management. So, how do we break this cycle and help people feel good about themselves and their management of diabetes? There are a lot of key drivers of the burden, and usually in our busy day, we don't have time to jump into the why of it, but it's really, really important to think about as think about new technology and tools to reduce burden and help people feel the freedom to live life and not have to think about when and where and how they're going to use insulin. It's really particularly important to note the emotional exhaustion, this perceived feeling of failure. When they see high numbers or feel like they have high numbers, people feel awful and they have a harder time continuing to do the medication management. There's also financial costs and then the long term health fears that in the diabetes distress scales, that fear of I'm going to die if I don't take care of diabetes is constantly in the back of people's mind. And it can really lead to paralyzing their ability to take care of themselves. So how do we reduce that burden? Well, before we get into that, this was a really interesting infographic that was just recently published in Diabetes Care. And what I really love about it is that it's this concept that as we have the GLP-1 and incretins, a huge importance, but we still need insulin and we still need diet and lifestyle modification. And for type 2 diabetes, we we do need AID, and we should be thinking about it more often than we do. So, as we talked about, there is a significant burden associated with type 2 diabetes, and it's affecting people's quality of life. And when we address this distress with simple solutions, it can help people get to their goal. What I wanted to also mention is that this is the third part of a three-part series, really diving into the use of automated insulin delivery systems in people with type 2 diabetes. So now I want to ask our expert, Pablo, as you think about the people with type 2 diabetes on insulin therapy, what do we know so far about AID systems reducing distress and improving quality of life?
Thank you, Kristen. I think that, again, as you mentioned in the introduction, this has been a fantastic journey because this is a journey that has started out many years ago with these systems. But in the beginning, there's a lot of people who just framed them in type 1 diabetes only because that's what technology seems to fall naturally. But today we know, for example, that this is very effective across many types of patients with type 2 diabetes. And we're going to talk later in the program that we need to kind of let go some of the misconceptions and pre-notions that we have about especially certain populations. We'll come back to that because we now know both from randomized control trials and from real world evidence that this really is clinically safe and effective, and at the end will improve quality of life like you were discussing earlier. One such system, for example, the focus of a recent review, and they basically look at many of the publications, and this systematic review and meta-analysis came back with, I think, three messages that I think are very important. First of all systems in type 2 diabetes will improve your time in range. Time in range, remember, is defined as a number between 70 and 180. There's another number that we use now, which is time in tight range. We may come back to that in the discussion. But the point being is that these are very effective, improving the time in range across the spectrum of type 2 diabetes. The second piece is that we don't do that necessarily in by paying a high cost in terms of um, safety, but we really get rid of the severe hyperglycemia that you see in type 2 diabetes as well as in type 1 diabetes. And remember, that has implications on infections, long term control, and all of that. But I think the part that is really exciting me is that we're not paying a high price in body weight or changes in the body composition, because the original idea was that when we improve insulin delivery, we're going to get more insulin in, and actually the patient is going to gain weight. That has changed. The new message says that we use the insulin more effectively, the way you ended up not necessarily needing more insulin. So, for example, one such trial that involved Omnipod 5, what called the Secure Type 2 Diabetes trial, basically used over 300 patients that were, for the most part, naive to AID systems. A lot of them have not been even doing carb counting. A lot of them have not been even doing intensive insulin therapy. The first thing that they notice when they enter the trial is that they do have this sense of failure. Patients have a high level of distress related to the fact that they were not able to control this disease, and the fact that they consider this a very moderate to very serious problem. So on the right-hand side, you can see that the AED systems not only improve the numbers that we just spoke about previously, but also they the perception of the distress also was diminished. So this is clearly one of those things that the systems are helping people. In another type of AID systems using tandem control IQ, similar observations. Now, this is a little smaller study, and they use a different satisfaction measurement through one of the available surveys. But at the end of the day, the message is that you get a lowering of the stress level, and in this case, specifically with this system, the overall satisfaction score improve, meaning that the patients are really, really finding that this is improving their lives. So we learned that from doing it in type 1 diabetes for many years. We knew in type 1 diabetes that reduced the stress. It also reduces the fear of hypoglycemia. One of the things that I think we're doing the best now in terms of sensors, but also AID systems, is to prevent nocturnal hypoglycemia. And this improves the life of people, especially when people have this condition called hypoglycemia unawareness that we can discuss further if we need to. But at the end of the day, translates in outcomes. And the outcomes are very, very, very important. And that's the focus of our discussion.
Thank you so much. I was really surprised by the level of distress in the secure T2D and that distress information. Pablo, were you surprised by that as well?
Absolutely. But I think that the Security 2 trial also show us that this is normal patient. This is not very sophisticated or very um, out of the norm. This is the what we used to say plain vanilla type 2 patients that are out there struggling, try to control their diabetes, and because they know that they're not getting the outcomes and they're trying hard, but the older tools, so to speak, are not helping them.
And Pablo, what do you when you are deciding how to start insulin or deliver insulin in one of your patients with type 2, what do you think about? How do you decide what to do?
So recently, Kristen, we went around and take a look at what are the elements, and so we break it down in three elements that I think are very important. Number one, we want to ask the patient what was being your technology experience and preconceptions. We want to know what is your exposure. A lot starts with the sensor, but a lot also have to do with technology in general. So basically, in a nutshell, we want to see how they use technology in your daily operations. So in the right hand side, you can see that this is we wrote down in this paper what is this sample conversation will look like, and in a nutshell, basically, what does technology does for you? Do you use a GPS? Do you use this? I mean, in the sense of glycemic control, that is the use of a sensor. How do you like to be helped to decide how much insulin to take? So that's level one. What is your experience and what is your preconceptions? Second level is, well, exactly how much of that the diabetes really impacts your daily routine, and how do you manage to do some self-management task, if you will. So, for example, meal, exercise, sleep schedules. How do you prevent highs and lows? So, in a sample conversation, we can say, why don't you walk me through your typical day? And people look at me. It's like, why do you ask me over and over the same thing? Because the typical day in my life changes also, and it may change due to work, due to family, due to this. When do you sleep? How you feel? Are you dealing with some other issues, either mental issues, social issues, or financial issues?
How much is considering carb counting part of the conversation with your patients with type 2 diabetes and AID?
So that was again another paradigm shift, because over the years we have basically based AID systems on the fact that we need precision in carb counting. The truth is that we cannot be further away from reality. The reality is that the systems are going to take all of that out of the problem list, and they're going to simplify. Sometimes by doing simple analysis of the composition of the meals, like deciding small, medium, and large meals. Sometimes that you just um, organize their day and tell them, okay, we're gonna do this much. Now, one thing that is very important to remember, that we still have to announce the meals. We're not quite there yet, where the system will be smart enough to detect the meal. So we're getting there, but announcing the meal remains still one of those tasks that is inevitable, and they have to control and do it.
And is for meal announcement, so say I have a patient who's really really eager to try it, but they're confused about what that is. How do you simplify meal announcement?
So one technique that we use, especially in type 2 diabetes, is we find the biggest meal of the day and then started them from there. And we say, okay, which is the meal that you have the most problem with? And if it's dinner, which is very common, but some people is lunch, we just say, well, why don't you just let the AID system take you through the day. Don't stress out about the other meals. Let's focus one meal, get your kind of feet wet, so to speak, on how to control that meal well, and then we'll go from there. 9 out of 10 times, the patients are start going doing on their own, experimenting with other meals, and then but this introduction into the meal announcement with only one meal in type 2 diabetes is a very useful tool, and we think that is something some for people to consider. The last one that we decided that I think is important is also how much you want to spend in terms of time to care and maintain the technology. And here on the right hand side, you can see some of the considerations that you might want to take into that in terms of insulin, in terms of the AID system components, and in terms of the sensor piece of that all is that.
Thank you. And helps me. That brings me to this question, and this was a question for myself that I wanted to share with the group. Is is I'm really rethinking who is right for diabetes technology. And so, how do I really look into my internal biases, which is a hard thing to do because it's really self reflection and saying, what, what perhaps misconceptions or antiquated beliefs do I have that are impacting my discussion with patients on the opportunity to try AID. And, for example, I had a patient who's Spanish speaking, who really wanted to try the study, and and I was afraid that it was too much for them, and I was able to work through that, and it was a little bit. It took a little bit more time and education, but we really got a long way in terms of diabetes management. This particular patient had an A1C in the 9 range and was really able to get it down to around the sevens. And I was really surprised by my biases that someone perhaps with language barriers or, the idea of carb counting was overwhelming, that AID has, the AID or artificial pancreas of the past that's really technical and difficult is no longer, and these current systems are much more simple, and we're moving more and more to plug and play. And so, I had a patient who, she was unable to do carb counting at all, so we just did medium. We said everything was medium size meal, and I'm like, all you need to do is hit medium meal and just tell the pump that you're eating. And then we put in there that a medium sized meal was 45 grams of carbs. But these automated systems, they start to think on their own. And really the only thing that we need to do is tell the system a meal is happening, and then it takes it from there in terms of its constant adjustment of insulin, giving more when you need more, pulling back if there's looking like the glucose is dropping to prevent low glucose. And so I've really changed how I think about diabetes technology, and I'm now challenging myself to try and offer it to everyone. And rather than saying why not? Why is diabetes technology not okay? Um, and Dr. Mora, before we go to the next slide, do you on that question, do you feel that a patient with type 2 needs to be familiar with CGM before they start AID?
Yeah, I think that CGM is one of those like the first step on getting onto the bike, so to speak. And so they have to, in my experience, have made a connection and at least make peace with the fact that they're going to wear a sensor. But the sensors have come a long ways. So I think that we need to also facilitate that. And then, but people are really using technology in daily life. So the more we make it a part of their life instead of part of the how we construct their life, the easier it's going to be for them.
Yeah. Yeah. And so we talked about acknowledging the barriers, and minimizing them whenever possible. Again, thinking, why not? I oftentimes will start with a CGM sample, which is real. The sample program is really helpful. Initiating that in the office, and then we can move, and that begins the journey. And it's a fairly low stakes way of jumping into technology. And Pablo, do you think AID systems should be initiated in the primary care setting?
Absolutely. So one of the things that has changed the most is how was difficult in the past that you needed pretty much a village to start an AID system. You needed someone very sophisticated to teach carb counting. You needed this, you needed that. Nowadays, it's as simple as a plug and play. And this is where we're going with the new systems that are coming in the future. In new systems, the idea is that you don't have to spend more time. You don't want to see this as a burden to your practice. You want to see something that is actually alleviates time in the practice because you do something for the patient and you clearly we can do that in primary care. Most of the individuals will be started at by pump trainers that are usually provided by the companies. And I think there's a lot of like technology based things that they remotely can help them to help uh, the pump initiation. The simpler you make it, the simpler it is. Clinics now are very able to download and try and track down a lot of this, and pump companies also, or AID system, offer a lot of support with specialized trainers, dietitians, and they're coming along with in terms of the language barriers and technical support. At the end of the day, the idea is that we have systems that are really not any more difficult than when you start, for example, to use a phone for GPS use, for communication, for family, and things like that.
Yeah. And as we're getting close to wrapping up this discussion, I challenge you to think of, based on what we talked about today, do you have a patient with type 2 diabetes who may may actually do really well on AID, and reduce the burden and help them get to goal? Perhaps someone that really needs some mealtime insulin, but the stress or anxiety around having to bolus with a syringe or a pen insulin pen is too much?
Yes, and I think the way that lately I have had a couple patients where the way that I phrase it that really made sense to them is that how can we make your life easier with insulin therapy in your diabetes? And the answer was, well, doc, can you just diminish the amount of tasks do I need to do? So if I can put the task to be down to just start an AID system device every 3 days, to give you an example, and then put the sensor every 10 or 15 days, that is much less task demanding and time demanding, and then let the system do a lot of the decision. And like you were saying, simplify, call a medium side medium and food, and then let the system figure out the rest. I think those are practical ways to present this information that the patient will take care.
I am so excited about the future. Pablo, can you tell us how you see the future for AID systems and diabetes technology, for particularly for people with type 2 diabetes?
Thank you. So yes, absolutely. So one of the things that I really see coming in the near future is what we have started to say more like a plug and play. Just basically no specific numbers, no complicated calculations. Start from something very straightforward, and the AI systems will figure a lot of things. But lately, Kristen, we also look at how does the data coming from the sensor and coming from the system are actually going to help the patient. So we've just recently um, presented the data at the American Diabetes Association that I want to share with you just very briefly. This is one of the systems that is available. This is specific system is called Discover, but has three features that I think is very important to discuss. Number one, can you start a patient from scratch? That is a patient that is never seen in the clinic. Upload the data from the AID system and the CGM in very, very quick time. We're talking about less than 15 minutes. That's huge for a practice. The second part is left, you can see that on the smartphone. Can we give patients some feedback by doing smart, small notifications? So, how good you are, or what's happening on the dinner, or you have had so many lows overnight. What's going on? These are the interactive piece that is going to take this thing to the next level. And at the end, what happens is the patients really come around, and without you having to do a lot of interventions, the patients really, really move them to own the system and to make it their own personal like helper, and ended up doing better in what in the process. They're more motivated, and the quality of life improves as well. So I feel like, I mean, we have come a long ways. I think that we have a beautiful future, and I'm very happy to be here to discuss it with you. But also, I'm very happy to be at this time in the management of type 2 diabetes.
Uh, that's really interesting because I feel like the pump companies and the engineers are so focused, and endocrinologists are sometimes talk so much about algorithms, and this pump algorithm's better than that algorithm. But the point you bring about that decision support, or that coach in your pocket, or with
Yes.
the AID system, is really, really interesting. So will it even, does it help with, like, food choice, or how do you see it helping, or where do you think it should help in the future?
Well, it's almost like a little angel that it sits in your shoulder and it's whisper in your ear and say, "Hey, you did really good," or "No, that extra piece of bread, really, you see what happened on the blood sugar?" So it's behavioral modification, Kristen, and I think that that's what they need. But they don't need it whenever we see them. We need it on the spot. We need it when they're out there. We need it when they're shopping. We need it when they go out to eat. So I think that's the frontier that we're getting to.
Yeah, it's incredible. It's like having a dietitian or a diabetes educator as that little angel cheering you on. That's
Yeah, it's like a mini Dr. Castorino kind of walking with them all the time.
um great. Well, we're gonna wrap up here. So, in summary, AID can not only improve time and range, reduce hypoglycemia, but also reduce the burden for people with type 2 diabetes who are trying to achieve their metabolic goals. And simplifying insulin delivery is a key part of reducing burden and helping improve people's quality of life. And team-based approach is always really helpful as we have this rapidly changing and emerging technology. And the future is, I mean, what we've got right now is incredible, and it's going to only get better. We're going to wrap up here. And on behalf of Pablo and I, we want to thank you so much for participating in this event. We hope that this has been helpful in guiding confidence as you extend the use of this technology for our type 2 patients.